Hello, good morning everyone. My name is Isabel Harrison and I'm a researcher on the SYNAPSE-2 trial. Welcome to our webinar. Thank you for joining us on the third presentation of the series on the role of inflammation in psychosis. Before I hand over to today's speaker, I just want to give a few details about the webinar. The presentation will last for 20 minutes and will be followed by 10 minutes to answer your questions. And as all attendees will be muted to avoid background noise, please use the Zoom chat function to submit your questions. And should we not manage to answer all your questions during the webinar, we'll collate them in a document which we'll distribute in a few days' time. And please note that this and the other webinars in this series and our webinars last summer will all be uploaded and will be to our YouTube channel, and that's accessible via our website, so they can be accessed at any time. So without further ado, I'm delighted to introduce today's speaker, Dr. Esther Coutinho, who is a consultant neurologist at King's College Hospital and a clinical research fellow at the Department of Clinical and Basic Neurosciences at King's College London. Dr. Coutinho will give a presentation entitled "The Patients Who Changed the Field of Autoimmune Neurology."
Thank you so much, Isabel, and thanks to the SYNAPSE group for inviting me to present today. It's a pleasure to be here. For my presentation today, I decided to give a talk on something slightly different from what is usually my research topic. But as you know, autoimmune neurology is a quickly expanding field, and we've heard about wonderful research that is being done to broaden our knowledge. But I always found very fascinating how major advances in autoimmune neurology, and perhaps like in no other area of neurology in modern times, have been made by very sharp clinicians and very careful clinical observations. So what I'll try to do today is to go through a few case reports that were instrumental in advancing the field and defining the field, because they challenge scientific thinking and led to further research. So let me try to share my screen to start the talk. All right, can everyone see? Yes, I think so. Good. All right. So another interesting fact is that although autoimmune diseases are in the differential lists of every neurological presentation these days, the concept of autoimmunity is fairly recent. So that was all to do with this man here on the left, Paul Ehrlich, undoubtedly a very brilliant man. He was Nobel Prize in 1908 and one of the founding fathers of immunology, because he described humoral immunity, the immunity driven by antibodies. But through his experiments in experimental animals that produced antibodies if they were injected with the blood of different species, but not their own, he concluded in a sort of generalistic way that the organism would abhor autotoxicity. So this concept that autoimmune disease does not exist, it persisted well into the 1960s. And it really was challenged by these other two men here on the right, Rose and Witebski, that in 1956 described how anti-thyroglobulin antibodies cause thyroiditis. So I think this is an impressive example how the words of an old respected professor can sometimes endanger scientific progress. This history of the discovery of the thyroglobulin antibodies is very interesting on its own, and I definitely recommend anyone who wants to read it on, and they can find it on the Golden Goose Award website. But we will focus on neurology. And about the same time, the concept of myasthenia gravis as an autoimmune disease was starting to be questioned. And it was around the same time or slightly later. And this brings us to the first case report that I will tell you about today, which is this publication here. I'm sorry, let me just reduce here so I can see. Oh, sorry. So this is 3 patients that were described in this paper from 1976, published in The Lancet by Pinching, Peters, and Newsom Davis. And they described the response to plasma exchange in 3 patients with severe myasthenia gravis. To give you a background of what was known at the time, the authors say, with regards to the pathogenesis of this disease, myasthenia, there is increasing evidence for an underlying immunological disorder. But although circulating antibody is to the acetylcholine receptor demonstrated, is doubt whether they are the direct cause of the disease. And without a doubt, the response to plasma exchange would establish whether a humoral factor, such as these antibodies, could be implicated. So there are 3 cases reported here, but I will tell you about the first one, which reports a 51-year-old woman with bulbar, ocular, respiratory, and limb muscle involvement, who had had 2 thymectomies and had initiated treatment with steroids, to which she had responded, but unfortunately she developed bone disease as a complication of these steroids. And the authors go on to point that at the start of plasma exchange, the patient was really impaired. She was unable to wash clothes by hand and had long neglected household tasks, which were problematic. Plasma exchange was performed, and the changes in function were considerable. She could eat a normal meal with ease and talk immediately afterwards. She was finding face washing easy, and she could now wash her own clothes by hand. And you can see here in the graph on the right a representation of this response to treatment, that with several courses of plasma exchange, her vital capacity improved, and so did the strength of her arms. So this first case report was very important because it proved that a plasma factor that was later proven to, without a doubt, to be antibodies against the acetylcholine receptor is the cause of myasthenia gravis, that it also helped to establish plasma exchange as a treatment strategy to this day in myasthenia gravis and other antibody-mediated diseases. But not only that, it established plasma exchange as an essential step in confirming the antibody basis of presumed autoimmune diseases, some of which we don't know the causal pathogenic antibody. The second dogma that I will tell you about is the concept that the brain is an immune privileged site. So this is a concept that comes from the 1920s, but it was reinforced by the experiments of this other man here, Peter Medawar, another very important immunologist, Nobel Prize winner on his work on transplantation. And what we saw was that if foreign tissues were grafted into what were thought immune privileged sites like the brain and the eye, these would be tolerated and they would survive for longer than if placed in the skin or in other organs. And this idea that there was an immune privilege of the brain came from the fact that the CNS is isolated from the immune system by the blood-brain barrier. There was a presumed lack of draining lymphatics. There was an apparent immunoincompetence of the resident macrophages of the brain, the microglia. So a series of case reports challenge this idea of immune privilege of the brain. The first one that I will tell you about is this clinical description of a new syndrome. So this is a paper published in Brain in 1960 by Brearley, Corsellis, and Nevin, and reports a form of subacute encephalitis of later adult life, mainly affecting the limbic areas. This is again a report of 3 patients, and I will tell you about case 1. So this is a male, age 53, who had been unwell for 6 weeks before admission, had become dazed and lethargic, and had profound behavioral and mood disturbance. He was profoundly depressed and agitated. He was perplexed and at times would laugh and prostrate himself on the ground. And apart from a variable tremor of the hands, there were no abnormal neurological signs. The patient went on to develop minor attacks, each lasting a few minutes, with nausea, an abnormal epigastric sensation, sweating, alteration in color, at times a curious smell associated with an inability to speak, all characteristics that now we know very well to be associated with temporal lobe seizures. And then he went on to have a loss of consciousness with convulsive movements. An EEG detected the focus on both temporal lobes, but the patient passed into a coma and died, and he had been ill for 14 months. On the neuropathology of this case, it was striking how the limbic areas were predominantly affected. And the authors describe how the parenchyma had been infiltrated with small numbers of lymphocytes, a few plasma cells, and many glial elements, and that particularly in the amygdaloid nucleus and the hippocampus formation, there was widespread inflammation. So this case report was very important because it recognized a distinct clinical syndrome, a form of subacute encephalitis, lasting longer than the known viral encephalitis to date, and affecting predominantly the limbic structure of the brain in elderly patients. In one of these cases, reported in this publication, there was an association noted with a tumor of the lung. And this association with tumors was later expanded in the works of John Corsellis. And now we know how limbic encephalitis is often a paraneoplastic syndrome. The etiology was unknown at the time, and the authors don't make a big discussion on the subject, but the recognition of this clinical syndrome was very important and later contributed to the work of Posner and Grause and the discovery of paraneoplastic antibodies. And now we know that these paraneoplastic antibodies are very important biomarkers for an occult tumor, but often patients do not respond to plasma exchange, as we believe those antibodies are not a direct cause of the disease. This is different from what was described later in 2001 as a new syndrome associated with likely pathogenic antibodies. So in this report, from 2001, published in The Brain by colleagues in Bologna and Professor Vincents, they described a patient with Morvan syndrome. Now, Morvan syndrome is a syndrome that had been described in the 19th century by this neurologist, Augustin Morvan. And the case report that is presented here has a very typical presentation for this syndrome. It is a 76-year-old man that presented with fatigue, muscle twitching, excessive sweating and salivation, small joint pain, itching, and weight loss. And over the next months, he developed confusional episodes, visual and auditory hallucinations, a very complex behavior during sleep, a particular sleep disturbance with progressive nocturnal insomnia and diurnal drowsiness, and also autonomic features as severe constipation, urinary incontinence, and excessive lacrimation. The polysomnography, as you can see here, revealed a total disruption of the sleep cycle pattern, continuous muscle activity, and cardiac arrhythmia, which are important hallmarks of this disease. And the diagnosis was questioned at the time, but because the patient had this continuous muscle activity, he was tested for VGKC antibodies that were already known at the time in the context of neuromyotonia, and he was found to be highly positive. The patient was plasma exchanged, he underwent 10 sessions, and you can see here a marked improvement of his recordings, and the symptoms completely disappeared after the 6th session. Now the patient went on to have 2 further relapses, both managed with plasma exchange, and unfortunately he had a sudden death. And the neuropathology of this patient suggested deposition of IgG in specific areas of the brain, particularly the thalamus, as you can see here in pink labeling human IgG. So this was indeed the first case report suggesting that antibodies can reach the brain parenchyma and cause neurological disease. It also established that CNS antibody-mediated diseases can be treated with plasma exchange and that these antibodies are likely pathogenic, but it was presumed to be a rarity at the time. Now this changed with the description of a different syndrome, NMDA encephalitis. And I could tell you about this case report, which is indeed the first report of an NMDA encephalitis as we know it today. So it reports a 19-year-old woman with reversible limbic encephalitis caused by ovarian teratoma. But I will not tell you about this case report because the authors, although describing this case, they failed to recognize this as a syndrome and the implications of this description. This was done by Professor Dalmau and colleagues in this paper from 2005. So it describes a paraneoplastic encephalitis with psychiatric symptoms and hypoventilation in ovarian teratoma. And it describes 4 patients that had in common an acute behavioral change and prominent psychiatric symptoms, followed by very rapid neurological deterioration with seizures, loss of consciousness, central hypoventilation, many of them requiring intensive care admission. These patients had ovarian teratomas. The tumors were resected in a few, and other immunomodulatory or immunosuppressive drugs were given. And the patients had, most of them, an impressive recovery. The authors go on to say that recognition of this syndrome is important because the subacute presentation of these symptoms in a young woman can lead to misdiagnosis. And despite the severity of the symptoms, the patients usually recover. The authors of this study also looked at something very important. They used rodent tissue, and you can see here in the top, the staining of sections of a rat with the patient's sera and CSF. It was found a specific pattern of staining where IgG was binding to the neuropil of the hippocampus in a pattern different from the one recognized in VGKC antibodies. They also stained rat hippocampal neurons grown in vitro, and they found that the patient's sera, the patient's IgG, was binding to the neuronal surface of the neurons rather than which was different from the intracellular paraneoplastic antibodies known. And these 2 methods were very important to development of the field, and they are still used today for discovery of novel antibodies. And this truly led us to a new era, the new era of CNS antibody-mediated diseases that we live today, where many other antigenic targets have been described, many different neurotransmitter receptors or other important proteins in the neuronal surface. And we now recognize that these diseases occur in men, women, children, and they are very important to recognize as the patients often respond to immunosuppression, particularly if they are diagnosed early on. So what about neuropsychiatry? So there have been important case reports and hints for an antibody-mediated pathology in several areas of neuropsychiatry. Neurodevelopmental diseases, as you'll hear from Professor Vincent next week, which interestingly also started as the description of a case report. Also in psychosis, in dementia, but surely there are many unknowns out there still waiting to be described. So we need you to find that patient and to write that case report that will define the field of autoimmune psychiatry, bearing in mind that a good case report draws attention to the clinical presentation rather than just an incidental serological finding. It's the clinical presentation, whether it's a novel phenotype without a known antibody, or a phenocopy of a common syndrome with an atypical symptom or sign that suggests an autoimmune disease, that is crucial. And these descriptions really need a detailed clinical, psychiatric, and neurological history. when there are serological findings associated, they should always be validated by more than one method, particularly if the patient presents with an atypical phenotype. And a well-documented, sustained response to immunotherapy is essential. And above all, it's important to do that extra step, recognizing the syndrome and its implications, rather than just describe as a clinical curiosity. So I finish here, and I welcome any questions. Thank you.
Thank you very much, Dr. Coutinho. That was absolutely fascinating, the historical overview. So we have a question from Dr. Thomas Pollack to everyone. And Thomas says, excellent talk. There is a study stream of interesting case reports coming from Japan, often with novel antibodies to glutamate receptors other than NR1, frequently in association with encephalopathies or with psychiatric syndromes. These reports are almost always totally ignored. Any thoughts as to why?
Hi, Tom. I think, well, first of all, it really shows that we are a West-centered scientific community. It's often these very good case reports coming from Asia are ignored. But I think the most important thing is the fact that some of these antibodies aren't available to be tested for in the majority of laboratories. But it is something that we need to consider, and we need to consider whether they are important for the kind of clinical presentations we see in clinic, definitely.
Can I just join in on that, please, Isabel?
Of course, we can hear you, Angela.
Because it's, I think one of the problems with those particular antibodies is that the techniques they use, from my recollection, are not the ones which we feel are suitable for proving the cell surface extracellular determinants on a protein. Now, there may be something new that I've missed, but that's my understanding. They've used Western blotting and other techniques. And I have to say that whenever we've tried to look for antibodies found by those techniques, we tend not to find them if we're using the cell-based assays, which now, as you've already made clear, are much more commonly used.
Okay, thank you very much, Angela. And Belinda Lennox has said, a really lovely talk, Esther, thank you. Demonstrates the power of clinical observation. Maybe we need to start considering plasma exchange in the psychiatric ward.
Always a trailblazer, Belinda. I think the important thing is to consider the possibility of an autoimmune disease in the psychiatric ward, definitely. And in those patients who have a suggestion of an autoimmune disease, and we need to have, established criteria for that, as there is criteria for autoimmune psychosis. Definitely, the suggestion is to try to treat and assess the response to plasma exchange. Yeah, I think that is something to consider.
Thank you very much. And we have a question from Dr. Rudkin. This is a really basic question, but what routine tests would you request if an encephalitis is suspected in a normal provincial psychiatric unit?
Well, there are criteria out there on what to request if there is a suspicion of an autoimmune encephalitis. And this is based on three main tests, which are brain MRI, EEG, and CSF studies. Now, whether they are available in the normal provincial psychiatric units, it's a different discussion. But definitely, if there is a suggestion of an autoimmune psychiatric illness, those should be requested. This trio of tests is very important.
Okay, many thanks, Esther. Let me know if there are any other questions in the chat. But just a reminder that those of you who weren't able to join from the start, that all these webinars, including Esther's, will be uploaded to our YouTube channel, so you'll be able to access the whole of the talk. Okay, thank you.
Can I ask a last question, please?
Yes, of course.
I think going forwards, do you think psychiatrists should be trained, should have more training in neurology?
Well, I have to say that I trained in Portugal, so my training is slightly different from the training here in the UK. But from my experience in neurology, we spent 3 months in a psychiatric hospital. That is part of our training. And I think the opposite should also be true. There are such similar specialities that it's almost unbelievable how apart they became with time. So definitely that is something that needs to be reversed to the beginnings when, neurologists and psychiatrists were the same.
Thank you.
Okay, we have a question from Bayode Shitu. In Nigeria, well, it's a statement here. In Nigeria, psychiatric trainees spend 3 to 6 months in neurology placements as well.
Yes.
Okay, thank you everyone for attending. I hope you found the presentation interesting and informative. And we invite you to join our next webinar, which is at 10:30 a.m. next Monday, the 12th of July, when Professor Angela Vincent of Oxford will present Maternal Immunity and Neurodevelopment, a Neglected Field. Thank you everyone and enjoy your day.